listen. Anand is one of the very experienced ENT surgeon who kind of manages a big hospital in India, Tamil Nadu, Coimbatore. He's a very well-known laryngologist, head and neck ENT surgeon, operates in Dubai and India, and he's very experienced. He is kindly sharing some talks, videos, factors influencing the outcome of laryngotracheal stenosis treatment. I hope you can hear. It starts with a pause. This video, then.
Good morning, everybody. I wish to thank the Dundee Institute of Head and Neck Education and the conference chairman, Mr. Jay Manikavasagam, for giving me this opportunity to present this to you. We are from a small hospital in India, and our experience in about 25 cases of laryngotracheal stenosis is being documented. Especially which all cases where we should not do extensive surgery, I am trying to concentrate, and also the techniques to follow during and after surgery to improve our success rates. Thank you for giving me the opportunity. Laryngotracheal stenosis are basically rare, but they are seen in patients where there is a lot of intensive care units available, and in a high density population country like ours, we have to manage. And we find that the present nasotracheal tubes with built-in suction have a larger outer diameter compared to the size, and they have a larger incidence of stenosis. Also organophosphorus poisoning due to the reflux. Pre-op considerations, we have to see what kind of tubes we are using after ventilation. You have to avoid using cuffed tube after the ventilatory phase is over, because the cuffs have no use in preventing aspiration and they only cause more injury. And avoid these metal tubes unless they are very good, which we don't, in our country we don't get very good metal tubes. We have to use double lumen non-cuffed tube. And as far as the dilatational tracheostomy is concerned, initially we had lot of issues from ICUs where intensivists were penetrating the esophagus and causing tracheoesophageal fistula. 2 cases we had to do that and put patch to close. We also find when you have a bilateral vocal cord palsy with tracheal stenosis, a deadly combination. And while treating tracheal stenosis, if you have a bilateral or unilateral vocal cord palsy, it's also a difficult thing. Thankfully, we have not had this particular problem in our series, and we should avoid it because it's difficult to solve. You have to do glottis first, then trachea next in such situations. Caustic injuries, because of their depth and severe stenosis, they do very poorly when it comes to open surgery, and it's better to avoid large extensive surgeries. And in case you have to use Kenacort injections and balloon dilatations for this kind of work. So it's better to avoid open large surgeries in this. Balloon dilatation up to 10 ATM, 6 to 10 ATM. We make these balloons in India now, so that has cut down the costs and we are able to use them instead of bougie dilatation. They are good and used appropriately in post-op period, and they give good results. Investigations, the stenosis length as shown by radiology, when you actually measure during surgery, it's a little longer during surgery, and we must keep that in mind. And CT scan is a mainstay, and you should look for tracheomalacia changes also. We should always do flexible scopy because it's a dynamic assessment and it gives a more real indication of the mucosal status, granulations, etc. inside. And we should not avoid doing that. It should be done. Also do tracheostomy, and we should look at the need for laryngeal drop depending on the length of stenosis and height of the patient. If it is a tall patient, it is easier to do these operations, especially tracheal. Shorter patients more difficult, shorter neck more difficult. The length of stenosis is more also more difficult. Vicryl is something which is weight to height, diameter to diameter is more stronger than silk, and 6 vicryls per side without taking recurrent laryngeal nerve into the bites with knots outside will do the trick. So when you are doing surgery, we should look at the upper level of the stenosis by passing a needle from outside and watching with an endoscope. Critical point is to see the exact upper level of the stenosis. Based on that, we can do the resection. We have to do a very good exposure by in cutting the thyroid and retracting laterally and dissecting all the muscles. When we expose cricoid and thyroid, the dissection has to be around the trachea without disturbing blood supply. Always keep in mind the position of the recurrent laryngeal nerve and avoid damaging it. You can even leave a little fibrosis and scar tissue there instead of damaging the nerve. The stenotic segment has to be isolated and resected, and the rest of the trachea is held in place with stay silk stitches and avoiding tissue forceps to hold the tracheal stumps. Once we remove the stenosis, we have to ensure the healthy margins are used, and we have to change the intubation from tracheostomy to nasotracheal, what we call cross-field intubation. And once this intubation is done, again we can rebuild the trachea around the endotracheal tube, nasotracheal tube. So when we have ossification, especially in multiple operations, these cartilages get ossified. Unless you have a small oscillating saw, it's difficult to cut these cricoids across or whatever way you want. You can drill the posterior lamina, but you have to use the oscillating saw. As I had already told you that if additional length of trachea is required, you have to do a laryngeal drop, and we may have to use additional stitches to take away the tension on the suture line. And for vicryl, it has to be 6 sutures per side with the knots tied on the outside of the lumen. So here we have the stay stitches which hold actually the trachea with the larynx to avoid the suture tension, and these tension relieving stitches, once they are applied, immediately the position of the neck has to be flexed to give less tension on the operated site. So we also put 2 stay stitches around the tracheostomy, so that the original tracheostomy which is closed, so that in an emergency post-op one can pull these safety stitches and do an emergency tracheotomy after the nasotracheal tube is removed. These stay stitches stay in place with artery forceps and are kept there for at least 3-4 days after nasotracheal tube. And we don't use Grillo stitch now, we use a cervical splint, so that the patient's neck is kept flexed. Up to 10 days we use this kind of splint so that the cervical suture line doesn't get tensed. Post-operatively, when we extubate the endotracheal tube, we pass a 8 Fg suction catheter so that it is just tip is jutting outside the endotracheal tube and clears out all the secretions when we are taking it out. Right tube feeds post-op has to be given minimal. Make the patient walk around immediately to prevent vomiting, and saline nebulization multiple times to prevent crust. Sometimes post-op balloon dilatation only after 20-30 days. Safety suture, as I told you before, kept on the trachea, pulled anteriorly for emergency tracheotomy, and oral feeding only after 10 days after removal of Rayleigh tube. Early mobilization is very important so that the stomach function improves, and also patient gets an overall sense of well-being with the nasotracheal tube. Once this period is over, we use laryngeal gargle, a technique we use with 4% xylocaine, a curved cannula, to anesthetize larynx and trachea. And do this.
ஒன்று ரெண்டு மூணு நாலு அஞ்சு ஆறு ஏழு எட்டு ஒம்பது பத்து.
This is a case where there was a tracheoesophageal fistula caused by dilatational tracheostomy. This was closed by open surgery. And another case, there was a tracheal stenosis with this, and it was also done. These are the patients which we have done, around 27 patients. Some of them have interesting history and connotations in which you can also learn. Ketaki is a patient whom I will describe later. She had the maximum number of surgeries and a very good result in our series. When you have operating children, small children with not fully grown larynx, once you do open surgery, it causes stoppage of growth. So when they reach adulthood, they will not have full grown larynx, and this causes issues. And the same thing happened to case number 9, which had to be operated in younger age with open techniques and resulted in a growth that ceased. There was another person who had this injury caused by a kite thread. In Southeast Asia, Iran, etc., they have this habit of kite fights with thread coated with glass particles. And this guy happened to ride a motorcycle when that thread was across the road, and that caused his problem, and had a tracheal stenosis which was repaired. Koili Das had a partial this one, only the voice was able to restore. We couldn't restore the tracheostomy. When it came to the other patients here, I feel most of the patients, if you see, are suicidal attempts. So most of our patients have come here for tracheostomy following suicide attempt and admission in intensive care units. There were 2 patients who came for after snake bite intubation in ICU. Overall, we were able to get airway and voice in 74% of cases, and some of them got only the voice back, not the airway. That's around 14%. Total failures were around 11. Many of them, they are not able to afford the second and third surgeries. That's one of the reasons for a high failure rate. And most of the patients wanted to have one single surgery and go home with that. After this chart, I'm just showing you one of the difficult patients of tracheal stenosis who had a total closure and a normal voice. You can listen to his voice now.
புதுக்கோட்டை பேர் ரமேஷ். பாண்டிச்சேரி போகும்போது பைக்கில் ஆக்சிடெண்ட் ஆயிடுச்சு. காவேரியில் கொண்டு போய் சேர்த்துருந்தாங்க. மூச்சை விட முடியாமல் கழுத்தில் ஓட்ட போட்டாங்க. ஓட்ட போட்டு 2 வருஷம் பேசாமல் கையை வச்சு தான் பேச முடிஞ்சு.
When patients have severe comorbidities, like this patient who had a major cardiac issue, 78 years old, he had to have a quick restoration of the airway with a tracheal stent, and this was done sometime in the early 2000s with an nitinol stent. He was able to manage with this for about 8 years, after which he had a natural end. Such stents are used only in severe comorbidity, but it's better to avoid in younger age group because ingrowth of granulation may be an issue with such nitinol stents. The solid stents are, I have not used them. I have only used these stents in my cases. We also can use medicines like mitomycin or any other topical application you want to use with the help of these FLS forceps what we have. and after anesthetizing with the laryngeal gargle we can use. This is the patient with post-op follow-up. We do regular flexible scope like any other institute, and this is post-op day 1 followed by 6. You can see the pseudomembrane developing. This is the pseudomembrane, but still airway is there. No need to do anything, and we continue to watch this, but give them lot of nebulized saline. This is after 2 days post-op day 8. You can see the pseudomembrane is still there, but the airway is still there. And when we look at these things, you should remember that the stenosis is actually 3-dimensional, the scope is 2-dimensional. So there are more gaps when you look at 3-dimensional. These are some of the sutures that are exposed in the trachea, which we always remove. Such vehicle stitches will cause granulations, and we remove. Now this up to 25 days in this case. This is the second patient with post-op day 1, and as we go on you can see some active blood clot there, but not enough to warrant immediate suction or anything. And you can see the airways there. You must remember that in a 3-dimensional way the airway is still good. This post-op day 7, all by the time it is somewhat better, it's clearing, and you can see one vehicle stitch exposed. You should remember there are 12 stitches that were put. 1 or 2 may be in the lumen. This is post-op day 61 after full healing. This is another patient while just removal of the nasotracheal tube, and he had a severe exuberant emphysema, and that is caused by a small defect. He had FLS on post-op day 9 found to have a flapping material, and we immediately remove it with the help of these local techniques, and without such material removed, you can get them inside and cause issues. So this is post-op day 9. This patient had probably not a watertight closure of the trachea, and that is why exuberant emphysema. On post-op day 42, here he still has a lot of granulations, and this is one of the longest admitted patients in the hospital. We had to use 8 watts of laser through flexible and under local anesthesia with fiber scope. We pass the laser through the instrument channel of the fiber scope, and use a smoke evacuator at the same time as well. This is 1 week post laser. Immediately you can see the response. Granulations do very well after laser. Unlike fibrosis, which does poorly after laser, cartilage is the worst after laser. Now you can see 2 weeks post laser, all the granulations seem to have disappeared. So this is now we can hear the actually patient speaking after this treatment.
ఆంధ్రాకి వెళ్ళాక మళ్ళీ ఆవేశం వచ్చి ఊపిరి అందేది కాదు. సౌండ్ వచ్చేది. సౌండ్ వస్తే ఇప్పుడు మళ్ళీ ఇక్కడ కొలాసి వచ్చి ఎంసీ హాస్పిటల్లో మళ్ళీ ఒక లాంచర్ పెట్టి క్లీన్ చేశారు. క్లీన్ చేశాక ఇప్పుడు బాగుంది. ఇప్పుడు సౌండ్ గట్రా ఏమీ లేదు.
This is another patient who had exuberant granulation, one of the caustic patients. We found to prevent emphysema, if you press against the old tracheostomy site, then the emphysema becomes less. She also had a lot of loose vehicle stitches inside. One of the worst closures we have had with loose stitches hanging into the tracheal lumen, and we had to remove these tracheal stitches. As you know, post-op day 12 you can't extend the neck and pass anesthesia endotracheal tube, so we managed to remove all these stitches using flexible laryngoscope and our technique of local anesthesia of the larynx and trachea. So this is a subglottic suture removal on post-op day 12. Not all cases, some cases will have this flapping mucosa debris or this loose stitches. Sometimes if the material is partially buried, it will come away with a little force, like in this case, And in other cases, we had to use a diode laser to cut the suture and then pull it out. But without taking out the suture, they have a lot of issues. This is another suture which we had to use a diode laser on post-op day 52 and remove this. Vicryl, they say it dissolves in 30 days, but we find that they can stay even up to 50 days. And we have to remove it, otherwise they cause granulations all around. You remove these vicryls by cutting the knot with a laser. This is up to post-op day 82. Uh, Again, some cases like this where it's a virgin case, you can resect out the stenotic segment nicely, results are great. But not all cases come like this. This is one of the cases which came after 27 times getting operated elsewhere, and we had to do an open laryngoplasty approach with celastic keel, and it failed in our hands. Then we had to use, after some time, a Rains modified frontal sinus stent and with mitomycin C dilatation, etc. That partially worked in the posterior glottis, but in the final time we had to use a cadaver laryngeal mold made from the ear mold silicone, which we can sterilize by autoclaving or whatever, and that was placed with costal cartilage, and that restored the airway as well as a voice that is not clean or nice, but just a little hoarse. But she was able to complete her education and finish her career. We do have fellowship opportunities for surgeons who want to come and be with us. I welcome you, whoever is interested, to get in touch with me in my email and I will help you. Thank you. In touch with me in my email and I will help you. Thank you.
Oh, that's a wonderful talk, actually. I think it shows a vast experience in a complex cases. Where is he there? Anand, he was there.
Hello, can you hear me?
Yeah, we can hear you, but you can open your video.
Can't see me.
Yeah.
Okay.
That's okay. I think it's fine.
I'm not able to open the video.
It's okay. That's fine.
Okay, I can answer the questions from
Yeah. The Q&A. Can you able to read, or do you want me to read the questions?
Please read the questions. I will open the Q&A also.
Okay. Right. When cricoid is very thick and ossified, what is your suggestion for sutures? Excision was from track 1 to track 4 ring, about 3 centimeter.
I think if you have an ossified cricoid, you have to do opening of the cricoid with an oscillating saw in the midline and try to put sutures from thyroid cartilage to the tracheal stump and avoid suturing into the bone. It is nice to say put some drill holes and put sutures, but it is possible, but I don't want to waste time on that. I have a recipient site in the form of thyroid cartilage in lower border from which I can take, or even cricothyroid membrane I can take. And the mucosa of the cricoid has to be separately sutured, and the skeleton of the cricoid has to be separately sutured. But basically, cricoid has to be widened. And I think you have a talk on subglottic stenosis. I'm sure my colleague Rajesh will talk about this post-cricoid drilling, where you can get thin thyroid cricoid lamina where you can put stitches. Does it answer your question?
Yeah, I think so. It's great. Thank you. And what size vicryl do you use?
30.
That's brilliant. And Is there any role of direct laryngoscopy and resection by coagulation followed by Montgomery tube placement?
I'm sorry, but both these words, if it comes to a patient where already it has been done and it come to me, these are one of the absolute indications I will not take for any reconstruction, because what I find, coagulation is not at all tolerated by your tracheal cartilage. It produces more and more scar. And Montgomery's tracheal tube, I'm sure you guys would have also seen how much granulation it causes above and below. And also the infection that comes between the silicon and the trachea causes a lot of inflammation. I find both Montgomery's T-tube as well as the coagulation not great as far as these surgeries are concerned. That's my personal view.
Great, thank you. And somebody's asking your email. Probably they want to discuss a fellowship or something. Probably if you can put it in the chat, that will be great. I think everyone is appreciating your presentation. It's really good. But I have a couple
I
of
think I'll do that.
I have a couple of questions. So after the
Yes, sir.
reconstructions, you intubate with a nasolaryngeal tube and you leave it.
During the reconstruction, we have the tracheostomy to start with. And during the reconstruction, we pull out the tracheostomy and pass the nasotracheal tube. And we keep it that way for 24 to 48 hours in the ICU.
Okay.
After that, we remove the nasotracheal tube without the tracheostomy is primarily closed. And one point which I didn't highlight, after this period, if in case patient has cough, they should press against the root neck with their thumb and then have a cough. Otherwise, they go for this exuberant emphysema, which is quite frightening if you haven't seen it happen. Does it answer this?
Yeah, that's great. Thank you. And Sam, do you have any questions? Because Sam and myself do laryngeal surgeries.
Can you hear me okay? Jay,
Yeah,
I
yeah.
actually don't have any question, just wanted to thank. And I thought this is a fantastic talk. I mean, maybe I should come and visit you.
Yeah, me too.
I don't think so.
It would be amazing to come and see you at work. Thank you so much.
We do, Mr. Sam, we do certain things out of necessity. And thank God that India has a lot of young people with, there are some of my residents who sleep in the ICU on the first day of the nasotracheal tube removal. They don't leave chances with the nurses. They are there. And because of them, we are able to do this.
Amazing dedication.
Great.
Thank you.
Thank you so much.
That's great. I think we are running on time, to be honest. I think it is, yes, yeah, we are well ahead on time. So we're supposed to have a coffee break from 14:55 to, so we are 5 minutes early. So shall we start at 3:10, please? That's a talk. Yeah, so we have a break and we'll start at 3:10, if that's okay with everyone. Thank you.